hyperkalemia, as we all know, it is a big problem for those using RAS blockade. One of the challenging trial was presented in the last Barcelona 2022, which is the Diamond trial. It's a great honor to be presented by Professor Amr Al-Hadidi, Professor of Cardiology from Cairo University.
بسم الله الرحمن الرحيم. اولا انا بشكر الدكتور اشرف رضا والدكتور تامر طبعا اللي ورا المجهود الرهيب في التشالنجينج جيم ترايلز دي، وصراحه هي فكره رائعه وما شاء الله كل سنه طبعا الترايلز بتزيد، واشكر كل الايافا بورد، مش عايز انسى حد يعني، كلهم عاملين مجهود رهيب الصراحه. My trial today is about a drug that can be used for hyperkalemia. But the point, we are not discussing this drug. The point is Dr. Mahmoud Hassanin with us, the head of heart failure in, maybe not in Egypt, maybe in the Middle East. I don't want to all we know that RAS inhibitors are the cornerstone of the 4 pillars of heart failure. So the point is why we are discussing this trial. This trial discussing the role of these RAS inhibitors in the treatment. All we know that RAS inhibitors is very important to reduce the mortality and morbidity, but we are associated sometimes with increased risk of hyperkalemia. Is this important? Yes. It may change your decision in treating those patients, high-risk patients, especially if you know that you are afraid from hyperkalemia. So if you have a RAS inhibitors, you will try to underuse of these RAS inhibitors, especially also the mineralocorticoid antagonists in those several patient population. So if you have a patient at high risk due to concomitant chronic kidney disease or diabetes, so you are usually trying to not to describe this drug to avoid hyperkalemia. Also, those patients with ongoing hyperkalemia start RAS inhibitors, but you see that the potassium is rising. So you would try to reduce. So if you reduce RAS inhibitors, you will have the less effect on the treatment of heart failure, and this also reflected on morbidity and mortality. If you had a history of those patients with hyperkalemia, so you never reach the optimum RAS inhibitor state, or you can definitely discontinue if you have this, you are afraid you have a hyperkalemia. So from these results, you will see that there is a suboptimal RAS inhibitor use, places these patients at long-term risk for cardiovascular events. And this analysis in this trial, the Diamond trial, that help you to see analyze the run-in phase on those patients who have to look for the potassium. So the potassium binder, patirumer, is a potassium binding. When it works in the gut, so it can exchange and lose potassium, and to avoid the rise of potassium. And this is very important in those patients with HFrEF for the risk of hyperkalemia. So what about the design of this trial? The design of this trial was done on 1,000 patients, nearly 1,000 patients, with 2 group of patients. Either these patients had hyperkalemia, above 5 millimole per liter, and on RAS inhibitors. So those about 422 patients, or those patients with normokalemia, and about 614 patients, and the potassium level within the normal between 4 and 5 milliequivalent per liter, and with a history of hyperkalemia leading to reduction or discontinuation of RAS inhibitors. So those patients are included, and the screening for those patients to detect those 1,000 patients. This study was started in 2019 and ended in June 21. This is why I'm saying this, because at that time, due to COVID and due to restriction and involvement of the hospital and the clinicians, this will change the aim of this trial at the start. The aim of the first trial was to detect the primary endpoint to see the effect on morbidity and mortality, but change it to detect the level of potassium after early as a primary endpoints, and this changed because of the decline of the number of the patients, and also discontinuation of some patients due to COVID, and a lot of discontinuation of some of these patients. And then initiate patiromer as it titrated up to maximum dose, 3 packs per day, about 8.4 grams per pack, and then optimization of AC inhibitors, ARBs or ARNI, and to reach the target dose more than 50% recommended dose, and initiate optimized mineralocorticoids, MRA, target dose 50 milligrams spironolactone or eplerenone. The aim is to reach the target for our heart failure patients. And at the start, for the first 12 weeks, it's a single blind run-in phase up to 12 weeks. So weekly visits to see those patients and to see the potassium level and the effect of these patiromer on the level of potassium. After 12 weeks, we'll see 2 groups now. One group, the target dose not achieved or other reasons to fail in the run-in phase, those about 160 patients. Randomized criteria will be on those patients reaching the target dose and achieved. 800 reach the target dose, and 160 does not reach the target dose of RAS inhibitors or ARNI in those patients, HFrEF patients, about 160. If you look to these numbers, you will see that 85% of patients achieved the RAS inhibitors and MRA dose with patiromer, and then the randomization was done according to reaching the target or not reaching the target. Then it was a double-blind treatment phase. So, and this will be continued for with regular visits, and then every week, and then every 3 months until the end of the study. And will be one the randomized will be have the patients with patiromer continued and placebo without patiromer group. So, what our aim from this? We are looking first single blind and then double blind randomization to reach the target or not. The aim is to explore the characteristics and demographics of non-randomized group and randomized group. Number 2 is to evaluate the changes in RAS inhibitors and MRA use in non-randomized patients. Number 3 is to understand the reason why those patients were not randomized. Well, not randomized? Yes, not randomized. Why? Because they did not reach the target dose for treatment of HFrEF patients. If you look for this table, you'll see that this is at the screening. Non-randomized, 2 minutes. Those patients at screening, if you look for comparing non-randomized and randomized group, you'll see that non-randomized are not reaching the target, they are older. If you look for the eGFR, it will be lower and more frequent diabetes and less. That's why we are using less frequent RAS inhibitors than randomized group. And if you look for the mean level at the primary endpoints for potassium, the comparing between non-randomized and randomized, you will see that the non-randomized will be the level plus 1.3 extra potassium higher, and while in the randomized group will be 0.03 potassium level lower than the target. So if you look for those proportions, if you compare RAS inhibitor titration, this is the mark. You can rise the RAS dose or not. If you can rise, this is with the randomized group because they continue on a patiromer and also have a good target and higher, and you can up titrate. If you look for the two colors, the blue and the green. If the non-randomized group, if you look, you will see that no titration, you cannot change the dose in 61%, and in 24%, you can up titrate. While if you look for the randomized group, you will see that 46 will be no titration, and 44 you can up titrate. This is very important. You can up titrate. If you look for the MRA, which is very important also, you can see that there is, look for the no titration in 66 and 26 only, you can up titrate, while the randomized group, which can up titrate the doses as you see. So if you look for the reasons why those patients are not randomized, either, 1 minute, either those because of, هو بيبص لكم يزود؟ طيب مش عايز يفتح لما تقول له اوكي اوكي خلاص اوكي why they did not meet the randomization criteria. You cannot increase the MRA, you can maintain on the dose of MRA or ARNI, or patyrumar dose less than 1 pack, not the usual dose, or the serum potassium less than 4 and more than 5. Other RAS inhibitors related reason, either due to potassium level higher or withdrawal, as we mentioned, or the non-compliance or withdrawal from the adverse events was nearly the same between the two groups. In conclusion, in the DIAMOND trial, population of HFrEF patients at high risk of hyperkalemia, 85% was able to achieve the target dose of RAS inhibitors, including an MRA, while maintaining the serum potassium when treated with a patyrumar. Patients who did not achieve the target RAS inhibitor MRA, and those who cannot reach the run-in phase, were on average older, lower eGFR, and higher frequency of diabetes than randomized patients. And if nevertheless, these patients experienced an initial reduction in potassium with patyrumar, and over 85% were able to maintain or up titrate what we
Dear
need
doctor,
from the
your
dose of
time is up.
Thank you.
Thank you, Professor Amr Al-Hadidy. I'd like to ask you if this drug is available in Egypt. Do you advise to recommend it at certain level of potassium, or only in patients who develop hyperkalemia while on race? The second question is, if I use it, should I use it lifelong, as long as this patient to be an addition to anti-failure drugs and RAS blockade, or?
Yes, we don't use this drug as a prophylactic. We want to see if this patient, if you know that this patient had a previous problem or a history of rise of potassium, or this patient with the complex patient, either if you have a chronic kidney disease, diabetes, and then you are looking for the potassium carefully. If you look, and also the kidney function, if you look that the eGFR is less than 30, you know that you will have a problem. So you can start when those patients, it's complex patients, you can start early than the usual one who are using the usual dose in those patients with no complex patients.
اتفضل يا دكتور محمود.
اللي جنبها اهو شغال.
يا دكتور عمرو الحديدي for this excellent presentation. انا عايز اقول ان hyperkalemia is very common in heart failure لسببين. اولا all drugs used to treat heart failure raise serum potassium ما عدا الصوديوم جلوكوز ترانسبورتر inhibitors. فدي نقطه all drugs بيرفعوا serum. نمره اثنين الامبيرد kidney function is very common في الهارت failure. فانا my plea انا بشوف in practice ان معظم العيانين they come back serum creatinine blood urea and no data about serum potassium. فبليز always request serum potassium in follow up with patients. يعني ساعات you are surprised تلاقي مفاجأ السيرم بوتاسيوم 6 6 ونص. فانا بيجي لي كتير قوي العيانين فولو اب من سيرم كرياتين بلاد يوريا لكن نو داتا اباوت سيرم بوتاسيوم. بس وانا بشكرك على this great presentation.
Thank you, Professor Amr, for a very clear presentation.
Thank you.
Any question? So,
SGL2 inhibitor, one option to decrease the incidence of hyperkalemia أو to treat. يعني ال SGL2 تعتبر counteracting مع ال MRA وال SGL2. شكرا دكتور عمرو.
truly. شكرا دكتور عمرو.
Thank you.
شكرين.